So in this section, I'm going to talk to you about the real dangers of looking at the automated report on the top of an ECG. It's very tempting. I do it, but I tend to do it right at the end when I've actually made my own interpretation. It's often a fail-safe, and my interpretation overrides anything that is on the top of the ECG. And on this slide, you'll see this is quite a tragic case of a patient who was anticoagulated on the basis of an irregular pulse. An ECG was appropriately performed because you cannot diagnose atrial fibrillation on the basis of an irregular pulse. You have to have an ECG demonstrating the findings of atrial fibrillation, which are no P waves and an irregular heart tracing. And here you'll see on this ECG the automated response suggests that there is atrial fibrillation with an abnormal ECG, but curiously at the top of the ECG there's a slight contraindication where the ECG states a normal ECG report. So already that should get you thinking, hang on, I'm not sure this is something we should be trusting. Now, it's fair to say that this is an irregular rhythm, and it's fair to say this is a poor quality ECG tracing, but this is what happens in real life. But if you look closely, there are clearly P waves below QRS complexes. And what causes the irregularity is actually what we call supraventricular ectopics, an extra heartbeat. So it's an irregular pulse, but there are P waves. So this is not atrial fibrillation. Now, unfortunately, this patient was anticoagulated, had a intracerebral bleed, and there are clear medical legal issues that were a consequence of these actions. So here are the problems. Atrial fibrillation, inappropriately diagnosed, despite the ECG suggesting it's normal. And if you look at the tracing at the bottom, you'll see that the QRS complexes are irregular. But look, where the little green dots are, there are clear P waves that you can see even though there is obviously artifacts on the ECG. So that's in first example of a patient who unfortunately suffered as a consequence of reliance on the report on the top of the ECG. Another example here is actually someone who was referred to me in clinic with atrial fibrillation again, but very clearly you will see that this is absolutely not the case because one, you've got an irregular pulse seen on the red dots here, but actually that ECG also showed completely normal P waves. Now, in this particular ECG, there's a diagnosis of atrial flutter with 4-to-1 AV conduction, which is complete nonsense because the bottom tracing, the rhythm strip at the bottom clearly shows, and the questions to ask yourself is, can you see a P wave? Yes, you can see a whole load of P waves there. Is every P wave followed by a QRS? 100%. The issue here is the P waves and the T waves look very similar, and that's been misinterpreted by the machine to suggest that's atrial flutter. This is not the case. It is sinus rhythm, and theoretically someone with atrial flutter may inappropriately be referred, and that wastes their time and upsets them, but even worse, may get anticoagulated. So here we've got a referral for someone with second degree type 2 heart block. Now, if that's the case, second degree type 2 heart block is a form of advanced heart block which potentially could progress to complete heart block and then asystole, so they need an urgent pacemaker. So this patient was referred to us. Again, if you look at the rhythm strip at the bottom and ask yourself two important questions. Are there P waves? Yes, there are. Are those P waves followed by QRSs? Of course they are. There's absolutely no evidence of any form of heart block here, but a kind of misplaced reliance on the automated report leads to an inappropriate referral. No cardiologist will obviously make the diagnosis of 2-to-1 heart block in a patient with sinus rhythm and put a pacemaker in. But there is the unneeded stress on the patient, the unnecessary referral, which obviously we all want to avoid.